think we're going to bounce to Jessica first.
Yep, you're all set.
Okay.
Greetings, I'm Jessica Garris Miller, Georgia Cares Coordinator at Athens Community Council on Aging. Thank you for joining us today. Our presenter, Joseph Weisenbaker, is a Georgia Cares volunteer counselor. His topic is an introduction to Medicare, and he will be talking with us about the basics of Medicare benefits. Joe, I'm turning it over to you.
Thank you so much. And thank you for that kind introduction. Just a preliminary remark, this is actually intended to be a very focused presentation on the very basics of Medicare. I can't tell you how many times I have gone through webinars addressing issues in Medicare and found myself after an hour and a half and 50 or 60 slides just sort of holding my head and going, okay, I think I got lost about 15 minutes into that. I really wish I could do it all over again at another time or what have you. So I've tried to organize this so it's sort of very, very focused and I hope reasonably short. In a week, we're going to have another one of these with a specific focus on Medicare Advantage plans that pick up and address a lot of the issues that we're going to be talking about today, but hopefully anybody who wants to also participate in those will have had a little bit of a chance to digest some of this and make use of some of the resources I'm going to share. So that is my goal. I think we're organized to pretty much take questions at the end. So if you kind of jot down any questions you have, and towards the end, if I haven't touched on them in sufficient detail, just let me know and we will roll right along. I think we have plenty of time. So I'm going to switch over to sharing the screen. And let's see. And of course, none of this looks exactly like I had thought. There we go. There we go. All right. Let me get all my various and sundry things out of the way. And we'll kind of focus in on the slides here. I hope that's where we're at. And we can kind of go from there. All right. Okay. All right. So our topic this afternoon is Medicare Basics, focusing on traditional components. And for the most part, what we're going to be looking at are the parts of Medicare that were there at the very beginning, starting in, I believe, 1965, when the enabling legislation was passed and Medicare itself began. I think the first enrollees in Medicare were former President Harry Truman and his wife Bess. That may be more than you want to know, but that's where it all got kicked off in 1965. Much of the information I'm presenting today comes from sessions that the Georgia Cares program in the state has sponsored and put on. Georgia Cares is part of the Georgia Department of Human Services, Division of Aging Services, and Georgia Cares is actually what is known nationally as a state health insurance assistance program, shortened up as SHIP, and we are funded in part by Medicare to provide unbiased information to help people make their best judgments about what to do with Medicare when they become eligible for it. And this session today is to sort of put things in perspective on the traditional components of Medicare to help people get a firm grounding. State health insurance assistance programs are available throughout the country. Every state has their own. Some states are less creative than Georgia, and they just call it their State Health Insurance Assistance Program, or SHIP for Medicare. Georgia's creative, and we have this program that does that function called Georgia Cares. And you may notice in the lower right-hand corner of your screen that this session today is coming to us courtesy of the Athens Community Council on Aging, which hosts one of the regional offices for Georgia Cares that Jessica is in charge of. Okay, the sorts of things that the SHIP programs touch on, predominantly Medicare education, education and outreach. Under Medicare education, understanding healthcare benefits, which is today's single biggest focus. We also cover wellness and preventative services, financial assistance programs to help people who have fewer financial resources be in a better position to afford what Medicare provides. We can also assist people with appeals and grievances, which are actually relatively rare because Medicare tends to be a pretty straightforward program once people get into it. There are 4 parts, you might say, to Medicare: parts A, B, C, and D. A and B and D are what we're going to talk about today. Part C are also what are known as Medicare Advantage plans, which represent private enterprises that work cooperatively with Medicare to try in a for-profit context to provide the same benefits that Medicare itself provides, perhaps with some additions. We also talk about Medicare supplement insurance because traditional Medicare parts A, B, and D do not cover the full cost of medical care provided through Medicare. And that's an important thing to bear in mind. And our goal is to provide impartial and personalized counseling. So much of what we do, unlike these kinds of group webinars, are actually done much more on a one-on-one basis. In this era of COVID, the volunteer Medicare counselors tend to work from home. And in part because of that, we are quite flexible in the times that we can work with people. I've regularly worked with folks on Saturdays and Sundays, on evenings. And it's just when people really need the help that we want to focus on being able to deliver it. And in the domain of education and outreach, we do presentations, traditionally often at senior centers around our multi-county service area. At counseling stations, we occasionally set up at libraries or at other kinds of locations, at health and benefit fairs, and in cooperation with community partnerships. Okay, Medicare, what is it? It's health insurance for people. Health insurance. Medicare is a payer for health care that we all get when we're enrolled in it, whether it be from a hospital or from a private doctor or at a clinic. it isn't something that a doctor is employed by. It is insurance, just like oftentimes we've had the ability to have health insurance either arranged by ourselves or through our employers before we became eligible for Medicare. The primary focus on Medicare is on adults 65 and older. The magic date for Medicare eligibility for most people is in the month of their 65th birthday. Now, there are lots of other people who are enrolled in Medicare who are not yet 65 years old. They are almost all are enrolled in Medicare because they suffer from disabilities that limit their ability to work or do other sorts of activities and come with a lot of requirements for health care that they otherwise probably wouldn't be able to get. People in that category of under 65 with disabilities include, among other things, people with ALS, people with end-stage renal disease, where they're on a list to get a kidney transplant or something like that, or any of a number of other debilitating conditions that make them eligible. The one set of things you need to bear in mind is that only US citizens or those lawfully present in the United States and have resided here for at least 5 years are legally eligible to be served by the program. Okay, who's responsible for Medicare? There's two sorts of things here. On the left-hand side of the screen, we see the agencies that are involved that handle enrolling people in Medicare, that deal with getting premiums that we have to pay for parts of our Medicare coverage. And the organizations that do that are primarily the Social Security Administration, which has probably the largest share of people it works with in the way of getting them into enrolled in Medicare. For folks who worked on the railroads, the Railroad Retirement Board handles their needs. And for federal retirees, people who have worked as employees of the federal government and are covered by health care before they retire there, the Office of Personnel Management assists them to be enrolled in Medicare. Now, once people are enrolled, who handles the rest? Well, what is called CMS, or the Centers for Medicare and Medicaid Services. That is the agency that is responsible for the greatest amount of what goes on with Medicare. Just as something as an aside, the actual people who do most of the individual level things under Medicare as people interface with it are actually themselves contract employees that work for companies that are contracted with by the Centers for Medicare and Medicaid Services to handle all of the nuts and bolts of things. So there isn't, unlike some misconceptions, a gigantic federal bureaucracy that deals with the trillions of dollars that get spent through Medicare every year. The actual number of bureaucrats is relatively low. Okay, what are the parts that we're focusing on today? Well, there's three. There's Part A, which handles hospital insurance, Part B, which handles medical insurance, and Part D, which handles prescription drug coverage. Those are the three basic parts to Medicare. Now, how does one go about becoming enrolled in Medicare once one is eligible? All right, for people who are already drawing by their 65th birthday Social Security, their enrollment in Medicare is automatic. If people are already retired and drawing benefits from the railroad board, those people are also automatically enrolled. And what happens when people are enrolled? Well, they get a Welcome to Medicare package in the mail. 3 months before they become 65, or if they are someone who's eligible for Medicare because of a disability, in the 25th month of their disability benefits, they get that package too. The package includes, along with everything else that describes Medicare, people's Medicare card, which is an essential sort of thing that once you get it, you really don't want to lose it. It's easy enough to find replacements, but if you're using traditional Medicare, when you go to see your doctor, when you go to the hospital, when you go to see about getting prescriptions under Medicare Part D, oftentimes you're going to be asked for your Medicare card, and that's the thing that you need to be able to produce. Now, for the people who aren't already retired, receiving railroad retirement benefits or Social Security benefits, you're not going to automatically be enrolled in Medicare Part A and Part B. And therefore, you need to enroll. And Social Security, unless you're retired from the railroad, is the site that handles enrollment. And the Social Security.gov website has a link to allow people to enroll in Medicare. It's a process that is very straightforward. It takes about 15 minutes at the most. And once you've got your ducks in a row in the way of documentation that you need that is specified there, it goes very, very quickly. And I suspect it goes equally well if you're a railroad retiree. If you're not into using websites, there is this 800 number, 1-800-772-1213. Or if you have audio issues, 1-800-325-0778, and you will be routed to someone who, perhaps after a 10 or 15-minute wait, depending on demand, will help you get enrolled with Medicare. The people there with Social Security are remarkably good at this. They deal with so many people with identically the same needs in terms of enrollment. And everyone I've ever spoken with who has gone through Social Security to become enrolled in Medicare has had nothing but nice things to say about the very helpful people, either at local Social Security offices, though those have very limited hours and I think require appointments to handle people, or the folks online. They're really good, they're really nice, they get the job done. And one thing you need to be aware of is that while Social Security retirement benefits, full benefit age has gone up, and it's now more than 65, the magic age for Medicare eligibility is still 65. All right. There are various times when you can sign up for Medicare if you aren't already enrolled in it automatically. There is what's called one's initial enrollment period. There are special enrollment periods. There is this thing called a general enrollment period. I'm going to focus almost entirely on the initial enrollment period, thinking that most of you who are listening to this are coming up on your 65th birthday, or if you have already reached your 65th birthday, are currently employed and covered by an employer's health care plan. And that basically deals with initial enrollment periods and special enrollment periods if you're transitioning from work-provided health insurance to retirement and losing the work-provided health insurance. Now, there are times during the year when it is possible to make some changes. The only one I'm going to really say much about today is the yearly open enrollment period. And we will get to that when we start to talk about Medicare Part D. All right, initial enrollment. It encompasses the month of your 65th birthday, the 3 months prior to that when you can arrange to sign up for things that will become fully functional the month of your 65th birthday, or the 3 months after the month you turn 65. So anywhere within that window is the possibility of signing up for things. All those things you might sign up for kick in the month that you turn 65, or if you delay, and I encourage people not to delay during the 3 months after that. If you miss that window, you're going to have to deal with some less than optimal consequences of perhaps not being covered by Medicare when you need it, or having to pay some kind of late enrollment penalty, or some mixture of those things. All right, during your initial enrollment period, in terms of traditional Medicare, you can enroll or join Medicare Part A, Medicare Part B. We'll talk about Medicare Advantage plans in a week, or Medicare Part D, dealing with prescription medicine coverage. There are some things that you can purchase that add to or help you deal with some of the costs that Medicare itself doesn't cover. But to enroll in any of those things, you have to be enrolled in both Medicare Part A and Part B. All right, Medicare Part A, what is it? Original Medicare coverage Part A is hospital insurance. It's to help you cover medically necessary inpatient hospital care or inpatient skilled nursing facility care. The things that Medicare covers in the way of inpatient hospital care include semi-private rooms, meals, general nursing, other hospital services and supplies, as well as inpatient care and rehabilitation facilities that are offered within the context of the hospital. And this includes both physical health as well as mental health issues. It's not just for if you get an inflamed appendix or a heart attack or something like that. There are a whole raft of things in the way of medical coverage that are included and covered by Medicare. Now, inpatient skilled nursing facility care is predominantly focused on people who require intensive skilled nursing care and rehabilitation following an inpatient hospital stay. Typically, the requirement for Medicare to cover that kind of care is that you have to have at least a 3-day inpatient hospital stay. So someone who's had a severe heart attack, someone who's had a stroke, things like that, then as long as they have been in the hospital at least 3 days, and most of those conditions require people to spend that at least that much time in them, then Medicare will cover initial inpatient skilled nursing facility care and rehabilitation. Okay, the things that Part A covers, if you require blood, that's one of the things that's covered. If you require ultimately home health care following hospitalization, that can be covered. For people who are judged to require simply palliative pain-reducing care as hospice patients, Medicare also covers that. Now, what's not covered? Private duty nursing isn't covered. Private rooms, unless you're in a situation where it's medically necessary for you to be in a private room. If the hospital charges extra for television or phone in your room, Medicare won't pay for that. If it's just part of the room, they, of course, that's all covered. And personal care items like razors or slipper socks, anything where the hospital is likely to charge you separately. Those are the kinds of things that Medicare won't cover. Now, how does Part A get paid for? For most of us who have worked for at least 10 years in jobs where we have paid into Medicare, we don't have to pay anything at all for Part A hospitalization coverage. Now, there are some people who, for whatever reasons, don't end up, when they become eligible for Medicare, having full 10 years of FICA coverage. There's the possibility that those people will get asked to pay a premium. And honestly, the premiums for Part A can become pretty high, like on the order of $500 a month. If you're further out than a few months before you're turning 65 and you're thinking about enrolling in Medicare, if you haven't reached that 10 years of coverage through employment, it would be a good idea to get there. Okay. Once you have Medicare Part A, if you're admitted to a hospital or a skilled nursing facility, there are certain things you have to pay. There's what's called the hospital deductible, which is this year, the first $1,484 for each benefit period. Beyond that $1,484, Medicare pays all the covered hospital costs for days 1 through 60 in a given benefit period. Now, for people who require more than 60 days of continuous hospitalization, Medicare doesn't cover nearly so much of remaining time, and people from days 61 to 90 of each benefit period are responsible for the first $371 per day of their hospital costs. And then if it goes even longer, in days 91 through 150, they're responsible for up to $742 of that hospital cost per day. Clearly can turn for a long-term stay in the hospital into fairly expensive proposition through the co-insurance that people are responsible for beyond day 60. In a skilled nursing facility, once you're released from a hospital and you're transported to such a place, the first 20 days in the skilled nursing facility are fully covered by Medicare. Beyond that, anything between 21 and 100 days of skilled nursing facility coverage, the enrollee is responsible for $185.50 a day. Now, you might go, what's a benefit period? Okay, a benefit period is a contiguous from the time of initial admission to a hospital until you are released from care, period. Or I should say up to 90 days beyond your release from care defines a benefit period. So someone who has been hospitalized, has paid their $1,484 hospital deductible, has been released, but has to be readmitted, say, within a month and a half. Whether it's for the original issue or for something new, they are still in that initial benefit period. So those folks wouldn't have to once again pay the hospital deductible. Outside of that window of 90 days, you become eligible for or burdened by, once again, potentially owing the hospital deductible if you're readmitted to the hospital after that benefit period. Okay, I think I have basically said much of this. You pay your Part A deductible for each benefit period. There's no limit to the number of benefit periods you can have, and benefit periods aren't calendar bound. So if you're admitted to the hospital in December, it's not like in January there's some restart of the clock and you become obligated to pay hospital deductible again. So benefit periods can span across the calendar. Okay, that's the big picture on Medicare Part A. Medicare Part B is medical insurance to help cover medically necessary doctor services, outpatient medical and surgical services and supplies, lab tests, durable medical equipment like wheelchairs and walkers and crutches, diabetic testing supplies for anybody who is diagnosed as diabetic and requires those. It also covers, as part of Part B, preventative services like flu shots or a yearly wellness visit with your doctor, or any one of a great many other additional preventative services. And it can also cover home health care that's medically necessary and appropriate. What does Part B cost? Part B comes with premiums for most people. This year, the standard monthly premium is $148.50. And that's paid every single month. Now, apart from that premium, what other sorts of things can you find yourself having to pay related to using Medicare Part B services? Well, every year, people are required to pay the first $203 for the services that fall under Medicare Part B. Now, there are some exclusions there. Your annual wellness visit, that isn't covered or affected by the deductible. That's paid for in full when you do it. Your flu shots, those are paid for in full when you get them. Other covered preventative services under Part B are generally handled without people having to worry about their deductible. They're covered in full. Now, once you have met your deductible for services that don't fall in that category of preventative services that Part B pays for completely, enrollees are responsible for what are called co-insurance payments. And the co-insurance is generally a percentage of the Medicare approved cost for services that you get from a doctor or a lab or something like that. The individual beneficiary is responsible for 20% of that, while Medicare itself picks up the other 80%. So clearly, things that you need in the way of treatments don't come for free. Medicare pays for the vast majority of that cost. Medicare has used its power in the marketplace to negotiate down costs for doctor services, costs for hospitalizations and things like that. But that still leaves people owing some if they need those services. In addition, some not hospitals, but doctors may require you to pay a fee called a copayment, like typically $10 or $20 a set amount, and that too is something that the beneficiary themselves would be responsible for. Now, I mentioned preventative services. What are they? These are things that Medicare pays for completely. When you're initially enrolled in Medicare, you get what's called a Welcome to Medicare preventative visit with your doctor. This happens once. The first time you see your doctor for your Welcome to Medicare visit is it. Then following on that, every year you're entitled to one wellness visit. These are visits where your doctor reviews your physical circumstances, your mental circumstances, does some very general assessments, provides advice about diet, things like that. But these aren't focused on treatment. They're focused more in the realm of what people used to think of as annual health checkups, though they don't include everything that might be there. There's other sorts of screening that goes on included as part of covered preventative services, abdominal aortic aneurysm screening, alcohol misuse screening and counseling, depression screening, diabetes prevention programs, flu shots, tests for glaucoma, screenings for lung cancer, screenings for people like me where they have to worry about their body weight and talk with their doctor about strategies to stabilize that or better yet, reduce it. These are all things that are covered completely as preventative services under Medicare Part B. Now, there are some things that Medicare Parts A and B don't cover. They don't cover long-term care in an assisted living facility or something like that, or even in, assisted living. That's what comes to mind most immediately. It doesn't cover routine dental care. It doesn't cover dentures. It doesn't cover cosmetic surgery. It doesn't cover acupuncture. It won't cover hearing aids or exams for fitting hearing aids. You might say, well, so much of this is important to health. Why isn't it covered? And the only thing I can say is these are decisions that were made in Congress when Medicare was enabled or in any of its many amendments since 1965. These things were just judged to be left out for whatever reason. Now, if you're hospitalized, if you have to see your doctor, obviously there's costly things you have to worry about. Your deductibles, except for Part B, you're going to be stuck with the Part B deductible regardless, but also the rest of the things that are called coverage gaps. Your 20% copays under Part B, your copays that might arise because of more hospitalization that Medicare builds in, lots of things. And to address that is something called Medigap Insurance, which is not itself part of Medicare. Medigap Insurance, otherwise known as Medicare Supplement Insurance, are policies that are sold by private companies that contract with Medicare. They fill in the gaps in terms of cost of things that Medicare already covers. Fills in the gaps in terms of paying for deductibles, in terms of Part A, in terms of co-insurance under Part A or Part B, and for co-payments. There are, at this point, I think something on the order of 10 different sanctioned kinds of Medicare supplement or Medigap policies. And they're all designated in a confusing way because we have Medicare Part A and Part B. They're all designated themselves by letters. Each plan with the same letter covers identically the same thing that any other company's plan with that letter designation covers. And the coverage is extremely standardized. Medicare has put out these rules, and they have Plan Gs that cover certain things. They have Plan Ns that cover certain things. And all plans that are sold have to conform to the clustering of things that are covered for plans with a given letter designation. To have Medicare or Medigap coverage, you have to be enrolled in both Medicare Part A and Medicare Part B. And the Part B, in addition to your Part B premium that virtually everyone has to pay, you also have to pay a premium to the insurer to be enrolled in their Medigap plan. And each Medigap plan covers one person. So while many of us in our lives and our careers have had family coverage, Medicare is actually individual coverage, and Medigap policies themselves are individual coverage. These are the plan types, with the exception of two things here in these columns. I'm not going to go into this in any detail. I'm just going to emphasize for you that this is confusing because there's so many different things you can have rolled up in a Medigap plan. If you take a look under this column that's headed by G, that is currently the most comprehensive available Medigap plan. And basically, if you're admitted to a hospital with a covered condition and you receive treatments that are approved by Medicare, if you have a Medicare Plan G, once your Medicare Part B annual deductible is met, you're not going to pay hardly anything, except maybe for razors or socks or personal use items that you might need when you're hospitalized. Plan Gs are the most commonly chosen of all of these options. Plan Ns are the next most commonly chosen. I'm not going to go into a lot of this detail about what gets covered because it's fairly complicated. Okay, if you decide once you have Medicare Part A and Part B to enroll in a Medigap plan, there's the question of what are you going to pay for it? And there's 6 issues that affect people's Medigap plan premiums. Your plan type, typically Plan Gs being the more comprehensive of those that are currently offered are going to be the most expensive. Other lettered plans that are sold are generally going to be less than that. Where you live, different states, different parts of states have allowed for different premiums for these Medicare plans. Each plan is actually licensed to be sold in a specific state, and the state insurance commissioners are the organizations that set insurance plan premiums in most states. So different states are going to have different costs associated with them. The age when you enroll, at least in Georgia, is the next big factor. Your gender. Generally, female folks pay less than male folks. Male folks, like me, are more likely to need more medical services sooner. So we end up paying more for the premiums for Medigap plans for us. Whether you smoke or not makes a difference. I think it's pretty standard $50 a month add-on to basic premiums if you smoke cigarettes or other tobacco products. The other sort of thing that affects what you pay for premiums is your insurance company. Because each insurance company is allowed to charge exactly what it decides it wants to charge. And so different insurance companies typically charge different things. Now, what can Medigap plan premiums look like? Here in the state of Georgia, let's suppose if somebody's signing up for a Plan G in Clark County, they're a non-smoking female and is enrolling precisely the month she turns 65. The monthly premiums can range from a low of $109.21 to a high of $290.64. And this is based on the different premiums that are charged for the same Plan G for the same kind of person by the different insurance companies. And you might say, well, wouldn't a company who's charging me $290 a month for my Medicare Plan G be basically offering more than a company that's charging me $109 for that same plan? And the answer is no, they can't. Legally, they're bound to offer the same coverage. So you might go, well, why should I pay $290 a month as opposed to $109 a month? And my response would be, exactly, why should anyone do that? I have met people who have fallen into some sort of inescapable trap in their mind of saying, oh, the more costly plan is somehow better. That would be probably an inaccurate thing to believe. So if you're searching for Medigap plans, it is wise to familiarize yourself with the range of costs that might arise and aim to take out a plan from a company that you have some reason to believe is moderately financially sound and trustworthy, but as close to the low end of this kind of range as possible. Now, can you buy these sort of things? The best time to buy is in what's called the 6-month period that starts the first day of the month you're 65 or older and enrolled in Medicare Part B. During that time, you have what are called guarantee issue rights, and a company basically can't ask you questions about your health status and use that to either set your rate or to decide they don't want to insure you. And you can also apply to be covered beginning the month you're 65 up to 90 days before that, your birthday. Now, here's the interesting thing. You're free to change these plans anytime after that. However, a company after that initial window is going to ask you questions about your health. And they're going to ask you questions about the prescription medicines you take and a whole bunch of other things. And for any reason they want, they can turn you down. So thinking about a Medigap plan, the time to think about it is during that initial enrollment period. Now, we've talked about a bunch of things. I'm going to finish up by talking about that third part of Medicare that's part of what is now considered traditional, though it was added on many years later, prescription medicine coverage. It's an optional benefit available to all people with Medicare. It's run by private companies that contract with Medicare. And the whole idea is these plans help you cover prescription medicines that you have to take. Their costs vary by plan. Most people will pay a monthly premium. Most people are subject to an annual deductible that's separate for Part D than it is for Part B. Most drugs you take will have co-payments or co-insurance attached to their costs whenever you get your prescription filled. Though there are what are called type 1 generics that some companies make available at no charge to people who are enrolled in them, because they figure people who need those kind of medications are going to have less likelihood of having to be admitted to the hospital if they can afford to take those particular kinds of medications. Let's see, there are phases to coverage. There's what the plans cover before you meet your Part D deductible. There's what's called a post Part D deductible period leading up to what's called a coverage gap that's defined by how much money you've had to spend for your prescription medicines. And in the coverage gap, generally, people have to pay more for their medicines, though not always. It depends on the medicine. And then once you've reached $6,350 in out-of-pocket expenditure, or I should say $6,550 out-of-pocket this year, you are covered under what's called catastrophic coverage, and you're only going to be responsible for 10% of the retail cost of the medicines that you take. Now, Medigap plans don't cover any of this. Let's kind of skip over late enrollment penalties. Some considerations. Each plan chooses the drugs they're going to cover. Each plan has what's called a formulary. So when you go to look at drug plans, you need to make darn certain that a particular plan will cover the medicines that you have to take. Oftentimes these plans have preferred pharmacies where you can buy those medications under those plans cheaper there. Also, there are plenty of pharmacies for a given plan that don't participate in a plan. So you really need to know that, because if you go to one of those pharmacies with that isn't part of a plan's network, they're going to say you have to pay full retail, and you don't want to do that. Let's see, you can choose a plan or join anytime during your initial eligibility period. Costs vary by plan. both in terms of monthly premiums as well as costs for specific medications. There's extra help available through primarily Social Security to help people cover Part D costs if they have very limited income and resources. There's nothing simple about making an informed choice about a Part D plan. You need to do a lot of research with the medicines you take. These are the resources. There's what's called Medicare Plan Finder, which we're going to certainly cover in a future webinar. You can call 1-800-MEDICARE for information about these plans. You can contact SHIP representatives to help compare plans. And that's what I do a lot when I help people. And there are multiple ways to enroll in a Part D plan, including directly contacting the company that sells the plan or working through the Medicare.gov website. Now, we're coming up on the end. Where can you go to get unbiased information about Medicare? Every year, Medicare publishes the Medicare and You booklet. It's about 120 pages. It is a wonderful resource. Everybody gets it. Medicare.gov is an online resource. I use it constantly when I help people. And Medicare can also be contacted by phone. And then finally, Georgia Cares. We are, in addition to those other resources, the only source for unbiased information about Medicare and the various and sundry things that are attached to it. And that basically, I think, concludes my presentation. And there we go. And I have taken far longer than I intended, so my apologies. Jessica, do you have anything you'd like to add?
Well, I would like to give participants an opportunity to ask questions if they have them. Are there any questions from our participants?
I'd just like to make sure that I sign up for the next presentation where you go into more detail. So is there a Zoom link for that you can go ahead and give us, or can that be emailed to us? How do we get that? Put it in the chat so we can copy it?
Yes, we will post it for you. And the date of the next webinar will be the 27th of April.
27th?
Yes, the 27th.
One week from today.
I believe we can use the same link. I can just change the date.
That's wonderful. Thank you.
Keep the same link. We'll do that.
That's really helpful. Thank you so much.
Thank you very much. It answered a lot of questions. Just we heard your lecture. Thank you.
Well, and we're going to be posting this online, and we'll provide folks provide the links to the recording. And as I said, SHIP as a program has the job of answering your questions, and that is something any of us Medicare counselors would be more than happy to do.
So I guess next week we'll see what the differences between Medigap and Medicare Advantage then, the disadvantages.
For sure.
Yeah. Okay. Thank you.
If there are no other questions, Joseph, thank you so much for the excellent overview. And I thank our participants participants for joining us today, and we look forward to seeing you next week.
Thank you. See you then.
Okay, bye-bye.
Bye.